In fact, if you take a subject like forensic medicine, in that there will not be much of long discussion like our tumor suppressor genes. You will have more number of topics which are only 5-6 minutes worth of review kind of topics about quick 5 facts. So it will run much faster. Only subject like pathology is taking little slow because we are passionate in teaching pathology. Probably that is biasing us. But yeah, pathology is the twin brother of medicine. No, so that's the reason. If we are sure about these things in pathology, automatically general medicine indirectly is covered. So don't be apprehensive. Give me another 3-4 days of time to finish all what I wanted to finish in pathology. Huh? So now, doctor, let's make a review on viral hepatitis from a pathology point of view. Acute viral hepatitis, when there is a jaundice along with a high elevation of AST/ALT, you call it as acute hepatitis. Can you tell me in which kind of hepatitis you will find 10,000, 11,000, 12,000 of AST/ALT? Ischemic hepatitis. Suppose if somebody is having any cardiac dysfunction or a cardiac pump failure, when the blood flow to the kidneys, to the liver decrease, high AST/ALT will be there. But after the restoration of the shock, patient's AST/ALT once more will normalize. Right? So, any hepatitis, acute means high AST/ALT along with jaundice. Then, what is the benchmark to define that it is a chronic hepatitis? 6 months, not 3 months, 6 weeks. Examiner will try to negotiate the figures with you. You have to be firm, it is only 6 months. Then hepatitis A. What do you want to say about it, doctor? Fecal-oral transmission is the underlying cause. And IgM type of anti-HAV will be typically positive. And good news about HAV is it is self-limiting in nature. It usually affects the children and adolescents. It's the common age group. Actually, this table is available in every book. There's no big deal. What is the difference between A, B, C, D, E, and what are their incubation periods, mode of transmission, their tendency to cause fulminant hepatitis? Basically, fulminant hepatitis tendency will be there for hepatitis B and hepatitis E. In pregnant women, it will be more than 30%. But overall, if a question is asked, most common cause of fulminant hepatitis means it is B only. Hepatitis B, don't answer it as E. But fulminant hepatitis, most common cause in pregnancy means it becomes hepatitis E is what you have to basically remember. Now let us talk about B. B is a DNA virus basically. And what was hepatitis A, doctor? Except B, everything else is RNA virus. Very good. Then you have that virion which is called Dane particle in case of the hepatitis B. The blood and body fluids transmit it, and we have a vertical transmission. 90% vertical transmission tendency will be there if the mother is hepatitis B positive, surface antigen positive. Then incubation period is for about 6 to 8 weeks is another common question in the exam. So the Dane particle. So what is the natural history of hepatitis B, doctor? Asymptomatic carriers are very common. And chronic HBV in few people, out of them, some of them, only few of them will become chronic hepatitis. And out of them, very few of them will develop cirrhosis, and very few of them will develop hepatocellular carcinoma ultimately. More than 90% of people, one of the favorite MCQ in the exam, resolution. Resolution is the natural clinical course of the hepatitis B. It is not cirrhosis. Then a lot of people would have become cirrhotic in the world. Chronic hepatitis and cirrhosis is very less. Cirrhosis is only 5% in the people, but still it is significant because 100 patients had hepatitis B means 5 of them end up with ascitic belly, with a cirrhotic liver, with hypoproteinemia, pathetic. So, fulminant hepatitis can develop in less than 1% where extensive necrosis of the liver will be there. Very rapidly developing hepatic failure defines the fulminant hepatitis. What is a very classical feature histopathologically in HBV infection, doctor? This is a typical biopsy of the liver in hepatitis B. Ground glass appearance of the hepatocytes is one of the very characteristic features in the case of the hepatitis B is what you are going to remember. Serological markers is mainly a discussion of microbiology, but still, quickly let us look into it. Surface antigen is the first indication that there is infection. Even before symptoms develop, HbS-Ag become elevated. That's very important. See, symptoms are starting somewhere here, doctor. Right? Somewhere this point they are starting. But the surface antigen elevation is starting much before the development of the symptoms. Right? So, much before the symptoms, hepatitis B surface antigen will elevate is what you need to remember. Core antigen. There is a phase which is called window period. What is the meaning of window period? If you look at the anti-HBS antibody, see this curve is anti-HBS antibody, doctor. It is starting from this point. And where is hepatitis B surface antigen is disappearing? Generally same point. But suppose at this point if you come, the levels of HbS-Ag are very low, but the surface antigen antibody has not yet appeared at this point when HbS-Ag is declining. During that point it is called window period, during which the core antigen is the one which is only elevated. That's the point which you need to appreciate. Then anti-HBS antibodies. Only after the acute infection is over, where the patient symptoms, acute symptoms have resolved, after the HbS-Ag decline, then only anti-HBS will typically elevate is what I want to underscore to all of you. Then if anti-HBS antibodies developed means it is a indication of recovery. It is an indication of recovery is what you need to remember. Then if a guy got vaccinated, typically in vaccine what you are giving without any virulence, you are giving one of the structure which looks like surface antigen. You are not giving virus. It is not like polio, oral polio. That surface antigen will go and stimulate the immune system to produce antibodies against the surface antigen. So you are giving a component of the viral structure which is the surface antigen only you are injecting. Right? It's a killed component. So it does not lead to any, it's not like a live attenuated vaccine. So what do you expect to see in a patient who has got a adequate vaccination? He must have sufficient titers of the anti-HBS antibody. Titers must be there. And once titers are high means forever they won't be high. They will also be falling down. Suppose if they are falling down, then once more you need to boost it by giving one more HbS-Ag. HbS-Ag in the form of vaccine. So that is all the story about hepatitis B. It's a very brief story. When to give interferon, everything in general medicine we will marathon it. When to give the pegylated interferon, when to give lamivudine, what transaminases will dictate, all those treatment decisions in hepatitis B we will discuss in general medicine. Now doctor, hepatitis C, what will you remember? It's also an RNA virus, transfusion related hepatitis it leads to. So the favorite MCQ of exam then. Most common cause for the transfusion related hepatitis. What is your answer? It is hepatitis C. Incubation period is 6 to 12 weeks. And the symptoms of hepatitis C are not that dramatic like hepatitis B. Lot of the patients with hepatitis C infection have only mild symptoms with waxing and waning type of liver enzymes, elevating, falling down kind of a picture. So from no infection, when there is an exposure, unfortunately, around 75% of them will go towards chronicity. And around 20% will go into acute state. But once they develop chronicity, a good number of them also can later on show spontaneous clearance. But cirrhosis is a feature in about 20 to 40%. And risk of hepatocellular carcinoma is 1 to 4% in chronic, in the people who develop a chronicity. Right? So, most common cause for the transfusion related hepatitis means, what is your answer? Hepatitis C is what you are going to tell. So, this is the typical cirrhotic liver in a patient who had hepatitis C. Then how do you diagnose hepatitis C, doctor? We use reverse transcriptase PCR reaction, and also we use the anti-HCV antibody titers also immunologically. And you need to monitor the liver function, and you need to do a serial liver biopsies to follow how is the amount of inflammation of the liver, what is the stage of the fibrosis, if the patient is going in a deteriorated state, everything you need to monitor. So hepatitis C is more tragic story than hepatitis B. They develop macronodular cirrhosis classically, hepatitis C. When do you call macronodular? When the size of the nodule is larger than 3 millimeters. This is a very important MCQ, doctor. Size criteria to call it as macro. 3 millimeters is what need to be remembered. Now, just like viral hepatitis, a similar pattern of macronodular cirrhosis and all these things, where else do you see? Even Wilson's and alpha-1 antitrypsin deficiency also can mimic the viral hepatitis. Chronicity in hepatitis C develops in nearly 85% of patients, doctor, is the unfortunate story. And after 20 years, 20%, 1/5 of them are going to develop cirrhosis who are infected with hepatitis C virus. Is another very sad figure about hepatitis C. But these percentages, doctor, at least for hepatitis, you need to remember, because they are the important numbers which examiner is interested whether you know or not. Then hepatitis D. Hepatitis D has got a little reservation. Only if the hepatocyte is having HBV infection. It is like our classmates. If you come to reading room only, I will also come to reading room. If you open Robbins only, I will also open Robbins. Of course, there is a pleasure in being surrounded by 15-20 friends like that and going to reading room every day. So, there's all the pleasure of MD preparation. So, co-infection and superinfection, two important aspects about it. It is completely dependent on the hepatitis B surface antigen, presence of it, hepatitis D. What do you mean by co-infection? Typically, if if both hepatitis D and hepatitis B infect same time the same guy, then there will be more severe illness than having only HBV, right? So, up to 5% of these patients will be having fulminant hepatic disease, fulminant hepatic failure. If it is only hepatitis B, fulminant hepatic failure risk is only 1%. Having two viruses increases the risk. Superinfection means what? Already the guy is a hepatitis B carrier. In him HBV got infected. Then what is the consequence of that? Typically the co-infection will lead to a higher rate of chronic progressive disease. If HDV alone comes, the combination will lead to more than 80% is the problem, chronicity. Then hepatitis E. It is also enterically transmitted, waterborne epidemics. We need to remember. Just like hepatitis A, it is also self-limited, but only in pregnant women we need to remember hepatitis E because it leads to development of fulminant hepatic failure is what you have to basically remember. Now, what are the other causes of viral hepatitis, doctor? Another very, very important question of the examiner. Epstein-Barr virus, CMV, HSV, especially HSV type 1 and CMV are known to lead to hepatitis in immunocompromised patients. Then adenovirus also can lead to development of viral hepatitis. Now let us talk about fulminant hepatitis and hepatic failure. In this is a rapid progression. More than 50% of these fulminant hepatitis are generally due to viral hepatitis is what you need to remember. But some drugs are also known to lead to development of fulminant hepatitis. Favorite question of the examiner. Don't forget, doctor, acetaminophen. Don't think paracetamol is very benign. Okay, at most you can tell you take 6 hourly, you take TID or QID. But if the patient is worried and keep taking every 1 hour, he will end up. I still remember one of a very good clinician in Warangal. His daughter, very good. He is otherwise a very good clinician. When we were children also, he used to be our physician. But ultimately, his daughter, paracetamol overdosage, she died. Because dad doesn't want her to get even 1 degree extra temperature also. So, a lot of times, as physicians and clinicians, will be over cautious about our children, which is not really required. And overdoing can lead to toxicity. INH, doctor, another very common cause. At least I might have seen 100 plus patients of INH liver failure. Very poor prognosis. Most of them didn't recover. That's the reason whenever you are giving anti-tubercular therapy, baseline liver enzymes, to order them is a minimum courtesy you need to have as a health surgeon tomorrow when you are telling the patients. And a lot of our patients have a habit of alcoholism, earlier might have had hepatitis infection. If they are women patients, transfusion related hepatitis, or some people will be regularly taking drugs. Some reason steroids regularly they are taking. So already liver enzymes, if they are elevated, you need to be cautious while giving the anti-tubercular therapy. So isoniazid, MAVO inhibitors, halothane, repeated administration of halothane, methyl dopa, amanita poisoning, any of them can lead to fulminant hepatitis. If you do an autopsy of a patient, doctor, who had a fulminant hepatitis, massive liver necrosis will be there. Not a single hepatocyte will be alive, is a classical feature. Now comes the autoimmune hepatitis, the next important form. Favorite question of examiner is, what is the type of HLA association? HLA B8, HLA DRW3 is what you need to remember. Lymphocytes, plasma cells, they will be infiltrating the liver in the morphology of autoimmune hepatitis. When will you consider autoimmune hepatitis as the underlying cause? If the viral serological markers first should be negative. Tomorrow don't argue. No. This patient had a viral infection and also I am thinking autoimmune means, we used to have a lot of such fighting in MD. Why did you think autoimmune means? Yeah, it can be autoimmune. No, but hepatitis B is positive now means the other residents used to fight. No. There can be hepatitis B positivity, still I consider autoimmunity means actually it is only due to hepatitis B, ultimately. So there can be absent viral serological markers. Then what are the serological markers suggestive that there is autoimmune hepatitis? Anti-nuclear antibodies, anti-smooth muscle antibodies, and anti-liver kidney microsome, anti-LKM antibodies. This is a favorite MCQ of the examiner. Anti-LKM1 antibodies are very, very classical. Then what are the three important drug-induced causes of hepatitis? You will not forget, doctor. Very common causes: alcohol, acetaminophen, and salicylic are the three important causes. Now let us talk about alcohol and hepatitis. Alcohol can lead to hepatic steatosis, which is basically fatty liver. Initially, it begins like a microvesicular steatosis. Ultimately, so much fat accumulates that it will push the nucleus to just one corner. Then ultimately it becomes a macrovesicular steatosis is what you need to remember. But what is the good news that you can tell your alcoholic patient? Sir, you are still in a steatosis state. If you stop alcohol, it is still reversible. That's a good point to be remembered. But the steatosis, which is basically only fat deposition, can ultimately progress to lead to hepatitis, and cirrhosis can be the complications is what you need to remember. Now let us talk about hepatitis. What is the favorite question in the exam? What are the classical histopathological hallmarks of alcoholic hepatitis? If you look at the hepatocytes, there will be swollen and ballooning degeneration of swollen hepatocytes. Protein tangles will be depositing called Mallory bodies. And the cell necrosis will lead to what are called acidophil bodies. These are all considered to be hallmark of the alcoholic hepatitis, in addition to steatosis and inflammation. If you look at cirrhosis, it is the ultimate end stage, and classically what type of cirrhosis alcohol leads to? It is micronodular cirrhosis. Where did we see macronodular cirrhosis? Viral hepatitis, classically, Wilson's, alpha-1 antitrypsin, even they are also classically macronodular. But alcoholic is classically micronodular, where it is less than 3 mm in size. This is also a favorite question of the examiner when we go to exam. Then that hepatocyte degeneration will be there, no? It is being surrounded by bridging bands of fibrosis in case of hepatitis caused by the alcoholic cirrhosis. Then other stigmata like portal hypertension, etc. will be there, and even alcoholic hepatitis associated cirrhosis is at a risk of developing hepatocellular carcinoma is what need to be understood. But there is a very, very important entity called, Dr. Saab, my jindagi mein kabhi bhi sharab ki bottle ko dekha bhi nahi, patient will be telling. Then why this fatty liver? So doctor, non-alcoholic steatohepatitis, NASH, is a very, very important diagnosis. Tomorrow, some of you will be radiologists. Routinely, you will be giving a report, it is NASH, it is fatty liver, and patient will be running to a gastroenterologist. Sir, mera liver fail ho gaya kya? So, very common, NASH at least you will not give, but fatty liver is a very common diagnosis in a fat, fertile, 40 female. Comes means some radiologists, even without putting ultrasound probe only, will write a report of what is going to be there in the liver. So, NASH, obesity, dyslipidemia, diabetes. In diabetes, there is an insulin resistance. Normally, insulin is a lipogenic hormone. Insulin resistance lead to lipolysis. The lipolysis will typically release a lot of free fatty acids. Those free fatty acids will get a right atmosphere to accumulate like triglycerides into the liver, and that lead to development of hepatitis, steatohepatitis, which is non-alcoholic in nature. So obesity, dyslipidemia, diabetes. One of the favorite MCQ of the examiner, doctor. Yeah, Prashant is asking a question. Will not alcohol cause both micro macro? Classical means micro. Classical. Later on, all the things will happen. Now, what's the problem called Reye's syndrome? During a viral illness, instead of giving acetaminophen to bring down the fever, if you give aspirin in pediatric population, then Reye's can occur, which is a fatal acute mitochondrial disorder. Ultimately, why fulminant hepatic failure with a severe rise of the enzymes, everything, is because of mitochondrial problem is there in those people. And liver and brain are the ones which get affected in the case of the Reye's syndrome. So this is an example once more of a non-alcoholic but steatohepatitis is what you are able to see. Then as an obstetrician, a lot of you are going to see acute fatty liver of pregnancy. Common MCQ in the exam is it first, second or third trimester? When is the acute fatty liver is an issue? Emphatic answer should be third trimester. Classically, acute fatty liver will be there. The liver enzymes will be mildly elevated. From there, up to fulminant hepatitis, anything can happen in these people. Once more, what is the underlying mechanism? Why fatty liver? Because defective mitochondrial fatty acid oxidation. Once more, is the underlying cause. Beta oxidation of the fatty acids occur in the mitochondria? No. If that is impaired, then there is nobody to oxidize them, they get deposited and that leads to development of the fatty liver of pregnancy. Then hereditary hemochromatosis. In this, there is excessive absorption of the iron, accumulation of the iron, which predisposes to cirrhosis, diabetes, and also deposition in the heart lead to the heart disease. We will discuss it in general medicine about hereditary hemochromatosis. Then what is Wilson? Wilson is autosomal recessive. The liver, eye, brain, kidney, any of them can get affected. In them also there is a hepatitis along with cirrhosis. Cave rings with the corpus deposition in the Descemet's membrane. All of you know very well. Then in the brain, which areas are classically involved, doctor? It is the lenticular nucleus of the putamen. So they develop dementia, psychosis, etc. Ceruloplasmin is very low. Then how about alpha-1 antitrypsin deficiency? It is also another cause for the macronodular cirrhosis. In them, there will be panlobular pulmonary emphysema. And where is the gene located, doctor? Ultimately in exam, that is important. Chromosome number 14. And they will also develop cirrhosis. They are at risk of hepatocellular carcinoma. Then one of the very, very classical histopathology. I didn't get time to project the histopathology slide here. Red cytoplasmic globules of alpha-1 antitrypsin. If you do a PAS staining, is a classical feature in case of the alpha-1 antitrypsin deficiency is what need to be remembered. So that is all the story, doctor. Hepatitis, full story, viral, alcoholic, drug-induced, autoimmune and systemic conditions, which you need to remember.